Hello and welcome everyone to another spotlight session at ACE. Just a little bit about myself. I'm a data scientist at the Regional Municipality of Peel here in Toronto. I have a PhD in data mining and visual analytics, where the focus of my research was on analysis and mining of complex and social networks. I'm the stream owner of network analysis at ACE, where we focus on network and graph algorithms to solve real-world problems. Just a little bit about ACE. ACE is a community of machine learning practitioners and researchers who have gathered around topics in AI research, engineering, and products. We host free live sessions like this one 3 to 5 times a week and produce premium content in various subject areas. To see more, visit https://ai.science and log in to access slides from this and other sessions. Also, make sure you subscribe to our YouTube channel called ML Explained to get notified about all the live sessions and other free content we publish. We currently have more than 30 different streams that are focused on various ML topics, and this session is network analysis stream. Hope you enjoy and come back. So today our speaker is Serina Chang. I'm going to introduce Serina. Serina is a PhD candidate in computer science at Stanford University, co-advised by Professor Yuri Leskovich and Professor Johan Ugander. She is interested in developing methods to model and make predictions over complex systems of human behavior, drawing from network science, natural language processing, and machine learning. Her most recent paper, published in Nature, analyzes the role of human mobility networks in the spread of COVID-19. So very relevant to our current scenario with COVID-19 spread. The findings received widespread coverage from over 200 news outlets, including the New York Times, Washington Post, Bloomberg, Telegraph, and NPR. Serina's research is supported by NSF Graduate Research Fellowship and Stanford Finch Family Fellowship. She is also a recipient of the 2019 Outstanding Undergraduate Researcher Award by the Computing Research Association and a member of the Phi Beta Kappa Honor Society at Columbia University, where she received her BA in computer science. So patiently listening to my introduction, Serina, over to you.
Thanks so much for that introduction. Thank you all for being here today. So the work that I'm going to be presenting is this Nature work that Faraz mentioned in my bio. It's titled Mobility Network Models of COVID-19, Explain Inequities and Inform Reopening. This is joint work from Stanford University and also Northwestern. My collaborators are Emma Pearson, Pengwei Ko, Jaylene Girardin, Beth Redbird, David Grusky, and Yuri Leskovich. So because this is a stream on network analysis, I'm going to start by relating how COVID and viruses in general have to do with networks. So the first key analysis is that viruses like SARS-CoV-2 spread through human contact. And specifically, there's an underlying contact network that modulates the spread of this virus, as illustrated here. In this contact network, if you have a simple epidemiological model, the idea is that an infected person can infect her contact with some probability beta. Then the people who have been infected by this first person can infect their contacts with some probability beta. And so you can see how the contact network modulates the spread of the virus, determining which people are even in contact in the first place so that they're able to infect each other, also modulating how quickly the disease can spread to the population and other properties of disease spread. For this reason, the contact network is really important, but many current models use crude estimates of the underlying contact network. So for example, some models use a fully connected graph, which basically assumes that anyone can infect anyone else. Or some models are able to include macroscopic trends, for example, airline networks. But still, this misses finer grained contact information, for example, who is mingling at schools, or who within a city are mingling at parks or restaurants, and et cetera. And so our premise is that this sort of finer grained mobility really matters because it affects the underlying contact network. Using this sort of mobility data to estimate the contact network, we can ask questions that are related to important issues such as stay-at-home orders. Did mobility reduction help to reduce disease spread? And where did mobility reduction help the most? We can also ask about reopening policies. So when should we reopen, or which places should we reopen later or earlier? For example, restaurants or gyms or cafes. We can also start to investigate super spreader events. So if you're thinking about this mobility network and you actually know how many people are going to specific locations, then you can ask which points of interest are especially dangerous. And finally, if you have a mobility network and you understand who is moving around, for example, at the degree of neighborhoods, you can start to explore disparities in infection rates. It's well reported that lower income and less white neighborhoods are infected at higher rates of COVID. And so the question then is, can differences in mobility patterns help to explain these higher infection rates among disadvantaged groups? So for all of these reasons, we decided to situate our work on trying to estimate the contact network using mobility data. And the premise is that if we can successfully estimate the dynamic human contact network with a mobility network, then virus modeling will be simple and accurate. And this is in contrast with many current models that need to apply many tricks in order to make it work. So our premise really is, if we have a complex, well-defined mobility network that captures the contact network well enough, then this will be such an important ingredient to the model that the rest of the model can really be quite simple. And you'll see that with this complex network and a simple model, we are able to accurately model the virus. So now I've motivated why this mobility network matters. So I'm going to now formally define what I mean by a mobility network. So in our mobility network, our goal is to capture the visits of people to places. And specifically, this takes the form of a bipartite network, where on one side you have nodes, which represent census block groups. So these are neighborhoods of around 600 to 3,000 people large. On the other side of the bipartite network, you have points of interest, and these are non-residential locations such as restaurants, cafes, grocery stores, churches, gas stations, etc. And so in this bipartite network, our goal is to infer for every hour of the day how many people from each census block group, CBG-CI, visited each point of interest, PJ. And here you see illustrated this bipartite network where every edge weight represents this joint distribution between census block groups and points of interest in every single hour. And so this network doesn't actually exist in any data set, but to step back a bit, we do have access to a data set from a company called SafeGraph, and we are able to infer this mobility network from the SafeGraph data. So I'm going to explain a little bit what data SafeGraph gives us, and then I'll describe how we applied a machine learning algorithm to infer the network. So what SafeGraph provides is anonymized aggregated location data from numerous cell phone apps. And they have a number of different data sets. The two that I'm going to talk about, first of all, is the patterns data set. So the patterns data set deals with points of interest, which again are non-residential locations. For every single point of interest, SafeGraph gives us the hourly number of visitors, also a monthly distribution of the home census block groups of these visitors, and also some various metadata about the points of interest. For example, its area in square feet, its median dwell time, which is basically how long the visitors usually stay at the point of interest, and also its category. So for example, a restaurant. So this is the information that we have about points of interest, which are one side of our bipartite network. The other data set that we use is called the social distancing metrics data set. And this deals with the census block groups. And in particular, SafeGraph tells us daily estimates of the proportion of people staying home in each census block group. And so we have information about each side of our bipartite network. And if you want to take a look at SafeGraph data yourself, it's available and freely available to researchers at their data consortium with the link posted below. So we have this data from SafeGraph, and we can use it to now infer this mobility network. So recall in our mobility network, we're trying to get the joint distribution of points of interest and census block groups in every single hour. And what SafeGraph gives us is basically the row marginals and column marginals of this hourly matrix. In particular, we have the number of hours. So for every single hour, we know the number of people who are going to each point of interest. Those are the row marginals of our matrix. And we also know we can estimate from SafeGraph data the hourly number of people from each census block group who have left their homes. And these are the column marginals. And we can also use SafeGraph data to create basically a noisy time-independent estimate of the matrix. But recall that we want an hourly matrix, so we can't just use the time-independent one. And so using these three ingredients, we can then apply an algorithm called iterative proportional fitting, which essentially creates a matrix that satisfies the row marginals and satisfies the column marginals, but is otherwise as similar as possible to the time-independent matrix as defined by Kullback-Leibler divergence. And so what iterative proportional fitting does is basically iteratively scales the rows and then scales the columns and scales the rows and then scales the columns in order to match the marginals until it converges. So that's the algorithm that we applied to infer these hourly mobility networks. Altogether, we model 10 of the largest metropolitan areas in the United States, and that gives us over 500,000 points of interest, nearly 60,000 census block groups, and 5.4 billion hourly edges that we're modeling from the beginning of March to the beginning of May, which was the period that we simulated over. And so just to give an example, Chicago was one of the metropolitan areas that we looked at. And here you're seeing an illustration of the inferred hourly mobility networks at 2 different points in time. So on the left, you're looking at March 2nd, 2020, and this is before a lot of the lockdown policies went down. It's a Monday at 1 p.m. And what you're seeing here is on the top layer, you have the points of interest. On the bottom layer, you have census block groups. And the gray lines indicate the weight, the number of people who are going from each census block group to each point of interest. On the right, you're seeing the exact same kind of plot, but this is for a different time, specifically April 6th. So 1 month later, still a Monday at 1 p.m., but post-lockdown. And the key is that you can see that the gray lines really decrease in density over time. And that's showing you how much visits went down before and versus after lockdown. And another thing to note is a lot of these lines are vertical, and that's what we'd expect. It basically says that most people within census block groups are going to nearby points of interest. So there's a vertical line between census block groups to points of interest. So that's the mobility network that we were working on. And then on top of that, we designed an epidemiological model that can track the infection trajectories for each of the census block groups. And the way that we did this was we used a simple SEIR model, which stands for susceptible, exposed, infectious, and removed. Susceptible people are people who have never been infected. Exposed means that you've been infected, but you're not infectious yet. Infectious means infectious, and removed means that you're basically removed from the equation. So maybe you recovered or you've self-isolated or unfortunately passed away. And this means that you can no longer infect other people, and you also cannot be infected anymore. And so in our epidemiological model, we maintain SEIR states for every single census block group. So in every hour, the model keeps track of how many people for each census block group are in S, are in E, are in I, or are in R. And so that's the key to how our epidemiological model works. At the very beginning of the simulation, which is the beginning of March, most of the people are in the susceptible state. But then as we simulate hour by hour, people can get infected either from visiting points of interest or by staying at home. And the way that we model people getting infected at points of interest are, we say that if you have both susceptible people and infectious people visiting a point of interest in a given hour, there is some probability of new infections occurring. And the infection rate of a point of interest, PJ, in an hour T, depends on a number of factors, including how many currently infectious people are visiting this point of interest, the dwell time of the point of interest, and we call that something that we get from SafeGraph data. It also depends on the area in square feet of the point of interest, as well as this free parameter called beta POI, which we fit to data. Similarly, we have infections that occur at home. And the way that we model that is we say that the infection rate at home depends on the infectious density of people in this census block group at that hour, as well as another free parameter called beta CBG, which we also fit to data. And so overall, our model actually only has 3 free parameters that are fixed over time. 2 of them I've already mentioned. There's this beta CBG, which is the base CBG transmission rate. And note that this is a single number. It's not a vector for all of the CBGs. It's a single number for all CBGs. Similarly, we have beta POI, which is a single scalar. It's not a vector. And then finally, one that I didn't mention is P0, which is the initial proportion of exposed population. We assume that infectious and removed states have 0 people in them. And then otherwise, we instantiate a number of people to be in the exposed state. And then the rest of them are susceptible at the beginning. So we only have 3 free parameters that are fixed over time. And so it's really quite interesting that then we do grid search over these parameter sets, and that turns out to be 45,000 stochastic realizations because we do a number of random seeds. And then we evaluate the model fit based on root mean squared error to the daily incident cases. And then we select parameter sets with root mean squared error within 20% of the best fit root mean squared error. And so this is how we maintain uncertainty in both randomness, because we have random seeds, and also uncertainty in the parameters themselves, because we're selecting parameter sets that are within the 20% of the best fit. So altogether, putting together our pipeline, I've covered all of these pieces. We start off with network inference, and that's the iterative proportional fitting step where we infer the hourly mobility networks. Then we have a bunch of different ingredients that go into our SEIR model, including census block group attributes, POI attributes, the hourly mobility networks, the free parameters, and then fixed parameters that we pull from literature. Then our SEIR model spits out some predictions for how many cases will be confirmed for each day or how many deaths will occur each day. We compare that against the observed case counts as reported by the New York Times, and we use that to calibrate the best fit parameter sets using the procedure that I just described on the previous slide. And then finally, once we have a fitted model, then we're able to run a series of interesting experiments, for example, asking counterfactual questions, testing different reopening policies, or analyzing disparities, like I mentioned at the beginning. So yeah, this is like a busy pipeline. The question is, does it work? And so now I'm going to describe some of our results, both in terms of model fitting as well as these experiments. So in terms of model predictions, we find that the model is able to fit cases quite well, observed cases quite well. We do two different fitting regimes. In the first one, we do out of sample fit. So we calibrate the model up to April 15th, and we fit it, that's basically our training period, and we calibrate the model up to that period, and then we test the model to see whether it can still predict well after that period. And you can see that this orange line, which are the reported cases, are falling pretty closely to the blue line, which are the model's predictions. And as expected, if you allow the model to calibrate over the entire period, the model fit does further improve. And you can see here that it's not just Chicago, we're able to fit all of the metropolitan areas that we model relatively well. And I think what's interesting about this plot is you can see that there are all types of different reported cases curves. For example, Dallas is going up pretty monotonically, and San Francisco and Philadelphia kind of level out halfway through, and New York just completely goes downwards. And our model is actually able to capture all of these different shapes of confirmed cases, and again, only with mobility data as the only time-varying parameter. The free parameters that we have are fixed over time. And so you can see that mobility is really doing a lot of work here. We also did a series of robustness checks. So as I was mentioning just now, mobility clearly helps the model fit cases, but how important is it to have a network? And so we compare the model that we have to one that takes in aggregate mobility data. So instead of having a full network where it has the breakdown of visits, both to POIs and from CBGs, it only has an aggregate mobility count, which is the total number of visits to any POI in any hour. And what we find is that our model, the network model's out of sample root mean squared error is 42% smaller than the aggregate mobility model's root mean squared error. This is quite interesting because it's telling us that it's not just general mobility patterns that's helping the model fit the data, but rather the network itself is doing some work in helping the model get an accurate fit. We also do another robustness check where we check parameter identifiability. So the way that we do that is we simulate the epidemic with known parameters, and then we run our grid search procedure to see whether we're able to recover the true parameters. And the good news is that, yes, we are able to recover the true parameters in every single one of the metropolitan areas that we model. We also do another, just a series of sensitivity analyses. We try sampling different reporting delay distributions. We switch up our parameter, the parametric form of our POI transmission rate, et cetera. I'm happy to talk about these, but the TLDR is that we did a bunch of sensitivity analyses, and it doesn't seem like the model depends too much on any of these smaller decisions. And then finally, we also do a data validation where we compare the SafeGraph mobility trends to the Google mobility dataset, and we find high correlation there. So that's quite reassuring. So I've talked a bunch about the model fitting, but now we can get to the fun part. So we have a fitted model, which means now we can use it to analyze a bunch of things. So for example, we can do a series of what if analyses. We can ask what if the magnitude or the timing of mobility reduction had been different in the past. We can also do a forward-facing analysis where we say we evaluate reopening strategies and ask which POI should we reopen earlier or later, or to what capacity should we reopen. And finally, we can try to use our model to explain both socioeconomic and racial disparities in COVID-19 cases. So to give you an example of some of our results, I don't have time to get through all of them, but here are some of the highlights. One of the analyses that we do is we do counterfactuals of mobility reduction. And the way that we do this is we ask, first we look at the actual mobility curves. This is again Chicago, and the black line is the actual curve. And you can see how much the mobility fell from the beginning of March to around the middle of March. And that's really quite a dramatic drop. We asked the question, what if we hadn't seen this level of mobility reduction? Or what if we started mobility reduction a week later? And so the way that we simulate this is first we take the actual mobility network and then we modify it, for example, by varying the timing or varying the magnitude. And then we run our SEIR model with the modified input network and we observe what the model predicts. And so using this strategy, we can test, for example, what if there had only been 50% of the actual level of mobility reduction, or what if there had been no reduction at all? And what we find is that social distancing really mattered. If you look at this black curve, which is what actually happened, and compare it to this hypothetical curve, which is what would have happened had we not reduced mobility in March, you see this huge gap. It's about a 6 times gap. And so it's basically saying that if we hadn't reduced mobility at the beginning of March, by the beginning of May, we would see around 6 times the number of infections. And this is in Chicago. In San Francisco, we saw around 10 times the number of infections. And again, this is just the beginning of May. If you extended that all the way to now, you'd see a really, really big gap. And so this is really just getting across the idea that social distancing mattered. The second thing that we can do is analyze different forms of reopening. And one strategy that's been quite popular is to reopen points of interest, but to cap the visits for each point of interest to some fraction of its maximum occupancy. And so we tried out this strategy, which our model is uniquely able to simulate because we actually simulate visits to individual points of interest. And so we can say what happens if we use, for example, a 30% maximum occupancy cap or a 20% maximum occupancy cap. And for every single one of these partial reopenings, you can evaluate, first of all, how many points of interest visits you would get in the month after reopening. And so this x-axis here kind of reflects economic activity. And you would think from a policymaker's standpoint, you would want to be as far right on the graph as possible because you want to maximize economic activity. You want to maximize visits to venues. But on the other hand, the further right you go on this graph, the further up you go as well. And this y-axis reflects new infections in the month after reopening. And so there's this really difficult trade-off that policymakers are dealing with between trying to return economic activity, but also wanting to minimize the number of infections we see from reopening. And so by doing this kind of analysis, we can look at, for different levels of capacity caps, how many visits you would see versus how many infections you would see. And even though this is a pretty difficult trade-off, what we find is a sort of hopeful finding that the curve is very nonlinear. And what that means is that a small reduction in visits can lead to a large reduction in infections. So for example, if you cap at 30%, you see around a 25% drop in visits, but you can reduce infections by 64%. Or similarly, if you do 20% max occupancy, you see a 40% drop in visits, but new infections reduced by 80%. And so this is quite a nice strategy to use because you basically get a lot of bang for your buck. You can do a small reduction in visits and get a large reduction in infections. Relatedly, instead of using different capacity caps, you might also think about reopening some sectors while not reopening other sectors. And so another analysis that we did is we simulated what would happen if you fully reopened, so not with a capacity cap, but what would happen if you fully reopened different categories of points of interest on May 1st. And what we find is that there's a lot of heterogeneity in terms of the impact on infections. So for example, full service restaurants, fitness centers, cafes, and hotels would result in the largest number of additional infections if you fully reopen them, as opposed to if you didn't. And the reason for that is twofold. The first reason is that since we're talking about opening an entire category, a lot of that is carried by how many points of interest are in each category. And restaurants, for example, there are a lot of restaurants in metropolitan areas. And so if you reopen all of them, of course, you're going to see a large increase in infections. The other reason is more nuanced, which is that every single one of these points of interest have varying degrees of risk. And so this comes back to the way that we model transmission rate, which, if you recall, depends on the dwell time, the number of visitors, as well as the area in square feet of each point of interest. And restaurants, fitness centers, and cafes and hotels all share this pattern where they tend to have more crowded points of interest and people tend to stay for a long time. And so it's because of both of these factors that we predict that these categories are among the most dangerous to fully reopen. Lastly, we can use our model to analyze disparities. And so, like I mentioned at the beginning, it's well reported that lower income neighborhoods and less white neighborhoods are getting hit harder by COVID. But what's interesting is that our model is able to correctly predict these disparities based on mobility data alone. So we don't give our model demographic data during fitting. We only use demographic data to analyze the model after it's been fitted and made its predictions. And so the question is, why is the model able to correctly predict these disparities based on mobility data alone? And after we asked that question, we discovered that there are two mechanisms in the mobility data that are driving these disparities. The first one is that lower income and less white census block groups had smaller reductions in mobility. And this is true for all of the metropolitan areas that we studied. What you're seeing here, this purple line, is the decile of census block groups with the lowest median household income. And the gold line is the decile of census block groups with the highest median household income. And what you can see is that there's a gap between the purple and the gold, and a consistent gap that basically lasts for all of the middle of March to the beginning of May. And so this really contributes to lower income and less white neighborhoods getting more infections. The other reason is more nuanced, which is that even if you controlled how much people are going out, even if you controlled which points of interest they went to, lower income neighborhoods would still be at higher risk, because within the same point of interest category, there are higher transmission rates at the points of interest that lower income and less white neighborhoods are going to, compared to the points of interest that higher income neighborhoods or more white census block groups are going to. And so to give you a case study, on average, one trip to the grocery store we evaluated was 2 times more dangerous for a lower income individual than for a higher income individual. And you can see that illustrated on the right here. If you compare the x-axis to the y-axis for this point grocery stores, which is showing you the transmission rate for the top income decile versus the transmission rate for the bottom income decile when they visit grocery stores. And the reason for that comes back to the same factors that I've been repeating over and over, which is that the grocery stores that lower income people go to, they tend to be more crowded. And specifically, we found that they're around 60% more crowded for lower income neighborhoods versus higher income. And people also tend to spend longer times there as well. And so these two factors contribute to grocery stores being more dangerous, one trip to the grocery store being more dangerous. And what's interesting about this is it suggests that even if a lower income individual and a higher income individual live the same lifestyle, in the sense that they went out equally much and they went to the same types of points of interest, the lower income person would still be at higher risk because of the way that these transmission rates are embedded within the places that they go to. And so this is a pretty striking result that I think can hopefully help to inform policy around how to reduce these disparities when we see the ways in which mobility might be contributing to them. So I've talked a lot about our findings. There are also limitations that we should discuss as well, both limitations of the data set. So for example, the mobility data does not cover all populations, for example, children or seniors or prisoners, or all points of interest. And so for this reason, there are certain categories, for example, schools, that we decided not to analyze. In exchange for simplicity, our model also does not include all relevant features to transmission. So for example, we don't model asymptomatic transmission, we don't model various distancing behaviors like hand washing or mask wearing, and we don't capture age-related variation in mobility and susceptibility within census block groups. So these are limitations that we traded off for the sake of having a simple model that can really focus on the power of mobility, which we see really is quite great. And so that's the takeaway, which is that these fine-grained mobility networks are essential to modeling COVID. even these simple models, which are missing all these features that I just mentioned, lead to accurate fits of the case trajectories in 10 metropolitan statistical areas. At the same time, they're extremely scalable. We're able to model over 500,000 points of interest and populations of up to 98 million people. It's scalable, but it also allows for micro trends. So you can look at individual neighborhoods and individual locations. And that sort of micro trend allows you to do these fine-grained analyses that can hopefully inform more effective and also equitable responses to COVID-19. And so in future work, we're hoping to continue working with this model to update it with recent data to incorporate more of those features that I discussed. We have some interest from multiple public health departments to try to work with them to inform current COVID policies. And on the research end, we're also interested in studying more the structure of the mobility networks and thinking about what the impact of that structure is on the model. So for example, thinking about how much variation there is across nodes or variation there is across time, and what the implications are for model fitting, as well as on policy intervention. So if you want to intervene on certain points of interest, what does the structure of the mobility network tell you about which points of interest you should intervene on and how you can do that prediction? And with that, I'm concluding my presentation. Again, this is joint work with Emma Pearson, who's at Stanford, Pongwei Ko, also at Stanford, Jaylene Girardin, who's at Northwestern, Beth Redbird, who's at Northwestern, David Grusky, who's at Stanford, and my advisor, Yuri Leskovic, who's also at Stanford. If you want to learn more about our work, I'm happy to take questions. You can also check out these links, including the paper itself, which is in Nature, the project website, and our inferred mobility networks are available through the SafeGraph Data Consortium, which they've agreed to share for us. So thank you so much for listening, and I'm happy to take questions now.
Thanks a lot, Serina. So I'll just give you a minute to catch your breath.
Thank you.
This was really, really useful. Okay, we've got some questions. Okay, so let's start with just some reading of the questions. The question comes from Aaron Maxwell. So how can you measure disparities in populations that don't have smartphones and therefore won't be tracked in SafeGraph? So obviously you mentioned your limitations about the data that you have. Just if you would like to add something.
Yeah, totally. This is a great question. SafeGraph and multiple researchers have done multiple analyses of the SafeGraph data, and they have shown that the SafeGraph data, first of all, is quite representative. They cover around 10% of the American population. And furthermore, they did more fine-grained analyses where they compared each census block group, and they tried to see whether they were overrepresenting census block groups from certain geographic regions, from certain racial demographics, income demographics, or educational attainment. And they find for all of these that the proportion of people in each of these groups compared to the American census are pretty well correlated. And so overall, SafeGraph does seem to be quite representative of both higher income and lower income, or more white or less white neighborhoods. That said, of course, there are limitations. And I think there are more people who are studying this now because mobility data has been such a popular ingredient in this analysis of COVID. So it's not just our work, but lots of people have been using SafeGraph and other mobility data in order to study the impact of non-pharmaceutical interventions. And so I think we will, as time goes on, find out more about specific ways in which SafeGraph data might be biased. But at a high level, we seem to find that it's quite representative.
Interesting, huh? Although it seems counterintuitive, right? You say that, okay, not everyone is carrying a mobile phone, so you cannot model the population accurately, but still the results seem to suggest otherwise, right?
Yeah, it's true that not everyone's carrying a mobile phone. And so, for example, if there's a population that we know definitely is not covered, so for example, children under 13 are not included in the data set. And for that reason, we did not we modeled schools, but we didn't analyze them as one of the top 20 categories, even though there's a lot of interest in reopening schools and seeing what the model can say about schools. We declined to do any analysis there because the mobility data doesn't do a great job. Similarly, we decided not to look at senior homes or prisons because of this limitation. But in terms of lower income and higher income, we do find that the SafeGraph data doesn't seem to overrepresent or underrepresent by too much for these different groups. And so that's why we went ahead and did our disparity analysis.
I see. So hypothetically speaking, if imagining like we had all the actual data of the mobility, then
Mhm.
your model would fit it perfectly, right? We don't need to worry about the
I
limitations
don't
there.
Not necessarily because so like I mentioned earlier, there are two types of limitations. There's the
Mm-hmm,
mobility data limitations, and then there's the model limitations. So, if we
mm-hmm,
had perfect mobility data, we wouldn't have mobility data limitations anymore. But the other side of the equation is mobility everything in terms of capturing how many cases there will be? And no, it's not. Like there are
mm-hmm,
these other relevant features like asymptomatic transmission, hand washing, mask wearing, age-related variation, all of these other things that are not captured in mobility data alone. And so I don't think the model would fit perfectly even then, but you would be able to reduce a big part of the error, I think.
agreed. Okay, so we've got a follow-up question from Aaron again. What do you mean exactly when you say interventions?
Interventions, yeah. So by interventions, I mean that loosely. Like we didn't end up doing causal inference in this case, but interventions being that policymakers probably want to make interventions on points of interest. So, for
Mm-hmm,
example, if you find that restaurants are driving a lot of infections, you might want to reduce the capacity cap for restaurants from 50% capacity to 25. So that could be an intervention that you would do on points of interest. And then the question would be, there's a number of different outcomes you can measure from the intervention. One of them might be how would mobility patterns change as a result of these interventions? A more downstream outcome would be after the mobility patterns change, what is the impact on infections? And how does this intervention impact the number of infections that you see for the population?
mm-hmm, I see. Good. Okay, so okay, so imagine if we had a different network than the mobility network. The bipartite structure.
Mhm.
If we had another underlying structure, it could be like any social network the way we model them.
Mhm.
How do you think your model would actually work in that scenario? Like take out the bipartite structure and just
Hmm.
create a flat structure.
Yeah. So are you thinking like
Just
a
the human
social network
contact,
where it's just you?
yeah, contact.
Yeah.
Yeah.
Yeah, so that's an interesting question. There's a number of reasons we didn't do that. The first of all, just
Hmm.
being privacy and lack of data. So we don't have, individual human
Hmm.
networks from the SafeGraph data set. What they gave us was already aggregated data, both aggregated over points of interest and also aggregated over census block groups. So we created a bipartite network for that reason. If you
Hmm.
want to go into individual modeling, I think there's it could be good, but there's a number of reasons that it might not be. The first reason,
Hmm.
like I'm mentioning, is privacy. Do we really want to have individual locations on every person? Another reason is computational tractability. Like it becomes much harder to model because you have so many more nodes because you're modeling each individual at any time. And another question is a lot of our model depends on points of interest. Like we want to know not just whether two people have come in contact with each other, but where they
Hmm.
came in contact. And that really matters towards the transmission rate. Like if two people came in contact at a park, that's going to be very different in terms of the likelihood of transmission versus if they came in contact at a restaurant, they were sitting near each other and they were talking and they were sitting there maybe for a full hour in an enclosed indoor space. And so in some ways, the aggregation to the point of interest level maybe gives us more information because we know where these people are coming into contact. And as we know from COVID, where the contact is happening has a very big impact on the likelihood of transmission happening. And so for this reason, I think our bipartite network actually serves its purpose quite well because we care a lot about where the interactions are happening. It would be possible to do it at the individual level as well. I think you'd have to tweak
Hmm.
the model quite a bit because currently our model is a metapopulation SEIR model, which
Hmm.
assumes various differential equations with populations. But you could, if you were able to tag every contact between individuals with its location, maybe you could do something similar.
Yeah, yeah. So the question came out of one of the previous work that I've been involved with. It was in a hospital setting, so
Oh
we
yeah.
actually could track each and every individual while people were moving, and the idea was to study how different diseases, like people coming in close
Mm,
contact, can transmit and even aggravate the diseases. So
yeah,
yeah, if you
that's
have like
interesting.
a close contact, like you have a close network where you know exactly each and every
Exactly.
person's location. Then in that case, how would you do? In this case, it
Yeah.
might be relevant as well with COVID, because hospitals and emergency departments specifically are the
Hmm.
one of the points of interest that, like you mentioned, where people come in close contact and yet have other
Yeah.
diseases that can aggravate
Yeah.
COVID-19 spread.
I think
Okay,
that would be
cool.
really valuable for like smaller populations where you know exactly where things are
Exactly.
happening. Yeah.
Exactly. Okay, cool. Okay, so I have another question. So you mentioned about the seed selection, right, for your model, and
Yes.
you're selecting randomly and generating a sample size from different samples randomly. So I was just wondering, how would the model change if we were to like pick individuals intelligently, like using some algorithm that
Hmm.
actually identifies influential spreaders. Like you might have heard about a lot of work about super spreaders, people
Yeah.
who are highly influential in social networks specifically.
Hmm. Hmm.
So what are your thoughts on that?
Yeah, so the reason that we did this P0, so the way that P0 works is it's P0 is a float that exists between 0 and 1, and it's basically it's a
Hmm.
probability. And we fit it. It could be anywhere from, I think we choose from, I don't know, like 10 to the -5 to 10 to the -3 or something. And
Hmm.
then once we choose a P0, then every single census block group, its number of exposed people is drawn from a binomial, which is the population size of that census block group, and then the P, the probability being P0. So just to
Hmm.
clarify what P0 is. And so your question
Hmm.
is, what if we could try to initialize kind of more smarter way? And the
Exactly.
reason that we did this is because we are modeling March 1st. And so this is
Hmm.
very early in the pandemic. And for most of the census block groups, maybe we have a few cases by this point, but it's very hard to tell based on case counts or death counts really how seeded the infections are in the population by this point. But I will say that now that we're trying to update the model and we're trying to, for example, start a simulation on September 1st, we are using
Hmm.
the observed case counts and death counts as a way to initialize the P0s. So we're doing actually a different P0 for every county because we have county
Hmm.
level case counts and death counts. So I think there is something to be said for non-uniform P0 if you have the data in order to be able to infer it. So this is a good direction. In terms of actually capturing individual super spreaders, I don't think that's something that we're able to do because we model entire census block group populations. And so you wouldn't
Hmm.
be able to do like a P0 for an individual. And if you actually look at our code implementation, we don't model individuals within
Hmm.
a census block group. It's really more, we have these 4 states, and the transition of the states from one time to time t+1 is a differential equation that takes the current states and then applies things related to those numbers, but it never explicitly models like individuals within the census block
Hmm.
groups. And so it would be difficult to like tag an individual with an exposure measure, with exposed or something at the beginning, and then tag them with individual infectivities.
Okay, cool. Right, I see. Okay, I'm just gonna ask you one probably last question before I let you
Okay.
go. So I guess the biggest limitation I would say for this work is the CBGs, right? How you decide them, right?
What do you mean by how we decide
The how
them?
you census basically the way you have constructed from the safe graph, you have
Mhm.
constructed the census blocks, so that kind of like aggregates the population, right?
I wouldn't
So
necessarily say that's a limitation for the reason that I
limitation.
described earlier, because I don't know
Hmm.
if individual would be that much better because actually we have a lot more information about census block groups because of their
Hmm.
demographics and all of the information from the census about census block groups. And it
Okay.
could possibly be, fine grained enough to do what we need to do. But yeah, go on.
Yeah, no, I see. So yeah, so just wondering, so you added on like the census data on those
Mhm.
CBGs to kind of like estimate, I assume, what type of population is that, like the demographics, like
Mhm.
both in terms of money, wealth,
Mhm.
races, culture.
Yeah.
So how accurate do you think would that be within that CBG?
Yeah, that's a good question. I mean, it's always possible that there's variation within census block groups, which there definitely is. But I think one thing that we do to, you know, kind of prevent against that or make that less of an issue is we only consider the deciles of census block groups with the lowest income and the highest income. So even if there is some within census block groups variability, the idea that the variability would be so large that the people in the lowest decile actually are higher than the people in the highest decile, I think that's unlikely. And also because we're aggregating over the entire decile, maybe you have one census block group that has a ton of within census block group variability, but once you aggregate over the entire decile, then the trends kind of still come out. And then we also evaluate it across all 10 metropolitan areas. So I agree, it's definitely a limitation. And we do mention that, I think one of the limitations that I mentioned was we don't model age-related, or in this case, income-related variability within census block groups. But I don't think, I think the broader trends speak for themselves. I think we can see that, at the higher level, the trends do come out. And if it was more variable, we would probably not see statistics such as for every single census, for every single metro area, we're seeing the lower income get infected more, or for most of the metro areas, we're seeing the less white census block groups get infected more, or we wouldn't see this kind of trend here, or we wouldn't see this kind of trend where for grocery stores, I think it was like 8 out of 10 of the metropolitan areas showed that grocery stores were more dangerous for lower income. So I think it's a good question, but I think if there were more variability, we might also see more variability in the broader trends too.
Yeah, I guess, I mean, I guess all the variations are nullified by the fact that you aggregate it, and then eventually when you run it, I mean, the model fits very nicely to the data. Agreed.
Yeah, there
Okay,
are always edge cases. They're always like, yeah, exactly.
Exactly. So one more follow-up question. Is it fair to say that one of your results with respect to disadvantaged populations, that health policy interventions need to happen disproportionately to the POI that BIPOC will attend?
I think that's a danger and should not be the primary takeaway. So I think that's a very good point, because we find that lower income, the points of interest that lower income groups might be going to tend to be more dangerous because they're smaller, and people tend to stay longer. And so if you wanted to take a pretty naive approach, you might just say, okay, let's close those down. But I think the more important takeaway is to say, okay, if these groups are at higher risk, what can we do to make these points of interest safer? Because these are grocery stores. These are essential places that people need to go to. You can't just close them down. I think what's more important is you come up with other solutions to make them less dangerous. So if you know these grocery stores are more risky, maybe you can provide more PPE, or you can provide more pickup services, or you can do something, provide more masks, provide more free testing that people are actually taking. I think there are a bunch of other ways aside from just closing down points of interest. Or you could try to do something with the capacity caps, which we found was quite effective. So maybe you can stagger out visits more, or you can try to find a way to make it so that the capacity never goes too high, but people can still visit these grocery stores. So I think the finding is really that people should pay attention, and they should consider disparate impacts on more vulnerable populations when they reopen. But it's not to say that you should take these findings and say, okay, we need to close down points of interest within BIPOC neighborhoods.
Exactly. Economically, it won't be feasible, right? You cannot just close down everything. That's not practically
Yeah,
possible.
that too, yes.
Okay, perfect. Perfect. Thanks a lot, Serina. I hope you enjoyed giving this talk. I enjoyed
Yeah, a lot of
learning
fun. Thank
a
you.
lot about this. So hope to continue the good work, and wish you all the best.
Thank you so much. Thank you all for being here.
Thank you. Thank you, listeners. Have a good day. Bye.